Thank you, Dr. Sahar. Now we're moving on to Dr. Stamatia Destounis. Dr. Destounis, can you hear us? Are you with us? I know that she's on the Zoom link now, so she can hear us? Yes? Okay. So the lecture is recorded, and Dr. Destounis is a breast radiologist and managing partner at Elizabeth Wend Breast Care Center in Rochester, New York, which is one of the biggest outpatient private practices in the country. She has been in practice after her fellowship for about 30 years, and she also serves as the chair of the ACR Breast Commission and is on the board of chancellors for the ACR and the chair of the ACR Breast MRI Accreditation Committee. She is a member of the ACR Practice Parameters Committee and the ACR BIRETS Committee, and also she serves as an RSAA board member for the Research and Education Foundation, which she is the current treasurer. She will be talking about step-by-step approach to reporting breast MRI.
Thank you so much for the invitation. I am so happy to be here. I want to thank the moderator and the chair people for the invitation. And we're going to get started. I'm going to share my screen. We're going to be discussing reporting by breast MRI, a step-by-step approach. So the MRI report needs to have several key sections within it: the clinical history, comparison to prior examinations, whether they're prior MRI or other imaging studies. We need to discuss the acquisitions that we obtained the MRI study with, and description of the findings. We're utilizing current MRI lexicon, which at this point, the 5th edition is the lexicon that we have out, our ACR BIRETS Atlas from 2013. We are actively working on the 6th edition, and that'll be out sometime next year, but we don't have that out yet. We're very excited about changes, but at this point, we have the 5th edition, and we're going to be discussing background parenchymal enhancement, foci versus masses, non-mass enhancement, kinetic curve assessment, and the final overall assessment in our reporting. Starting with the clinical history, we want to describe the clinical question that the healthcare provider, the clinical team has for us. What is the problem that this patient has? Because our goal with MRI is to answer that question. Is it a lump? Is it skin change? Is it bloody discharge? Is it a new diagnosis of breast cancer? And they're looking for multifocal disease. Any patient's symptoms should be listed as part of the clinical history in our MRI reporting. If we have any history of prior needle biopsy or surgical biopsy, we need to discuss that in our clinical history, add dates and the pathology results. Other things that may be important to add here are if a patient is on hormone therapy, that may change the background parenchymal enhancement on MRI. If they're menstruating and they're premenopausal, what phase of the menstrual cycle they're in. If they're a high-risk patient and they've had personal history of breast cancer, a very strong family history, and they're anti-hormone medication, that definitely changes how the breast tissue looks, so we have to add that. If they've had radiation treatment, just like surgery, that creates changes that we notice on MRI that we have to report. The patient is a high-risk patient, whether genetic mutation or strong family history. We need to add that as part of our clinical history because that is important for this patient and the reason for the MRI examination. Comparison to priors is also very important. Stability of findings that we can see that been there before. If we have the prior studies, then we can be very strong when we interpret that MRI. A finding may be new, a finding may be getting larger. So the date and the type of prior imaging needs to be reported. If we have a prior mammogram or ultrasound or contrast enhanced mammography study that actually found something and that led to this MRI exam, we have to mention that the date and what the finding was, because if that's what prompted this examination, we kind of have to close the loop and be very thorough when we explain this to the patient and her clinical team. For acquisition reporting, since there's no single method in performing breast MRI, we need to report the magnet field strength, what are our breast coil specifications, what pulse sequences we did, and any other parameters, because these can be quite variable in clinical practice. We all have to use dedicated breast coils, but the rest of the parameters can vary quite a bit. So part of the acquisition reporting is what pulse sequence we use and what technique. Are we doing T1 or T2 water-based weighting images? Are we using fat suppression? Also, are we imaging both breasts? Some patients have had mastectomy, we're only imaging one breast, or we're doing interval follow-up after a benign finding or a prior MRI biopsy, and we only may do one breast, so we have to state that in our report. Typically, breast MRI is a bilateral contrast enhanced examination, but there are cases where it may not be. So the plane and scan orientation have to be listed, and any other pulse sequence features are pertinent to the exam. Part of our reporting has to be the contrast injection and the method. So what agent we're using, how much the dose was, the mode of administration. There's a strong preference here for the injector and not to do a hand injection. The dynamic scan parameters need to be reported, how many post-contrast acquisitions we're doing and what is the time interval between each scan. If we're doing post-processing, then we have to state that. Is it image subtraction, MIB, the maximum intensity projection, what surface type of rendering are we doing for our images and what kinetic analysis? We have to be able to add that to our reporting. Now, some patients have extensive post-surgical changes and surgical clips. There's a lot of artifacts which have to be stated. There may be fat suppression failure or something may go wrong with our contrast injection. Those are things that we have to add to our acquisition reporting. And there may be patient motion, so that all has to be stated. BPE is something that we're going to be describing, and as per our MRI lexicon, background parenchymal enhancement, usually that assessment occurs at the first post-contrast image at 90 seconds, and we will list it as minimal, mild, moderate, or marked. That's how we describe it. If we wait to a later point after that first post-contrast, you may get progressive enhancement, which will artificially change the description of your background parenchymal enhancement. It does occur in patients that are postmenopausal, so it's not directly related to the amount of fibroglandular parenchymal. It is evaluated with respect to fibroglandular tissue present, but not the entire volume. So when we look at breast density on a mammogram, there is not a direct correlation with BPE, because you may have a patient with scattered breast tissue on the mammogram and very high background parenchymal enhancement on MRI, or a patient with extremely dense breast tissue on the mammogram and very low background parenchymal enhancement on MRI. We know that high density in a mammogram makes the mammogram less sensitive, but with MRI, even when we have marked BPE, we're still able to identify cancers. So we know MRI is different, and BPE doesn't work the same way as breast density on the mammographic imaging. So the enhancement may be symmetric or asymmetric. We're looking at mirror image enhancement. If it's symmetric, then usually that's suggestive of something we don't have to worry about, something benign. There may be preferential enhancement in the outer part of the breast, upper outer quadrant, or where the blood will pool or localize along the inferior aspect of the breast. If you have asymmetric enhancement, that could be benign or malignant. We're looking at the marked asymmetry in the right set of images, and that's another modifier for non-mass enhancement, so we have to add that. A focus is a small, less than 5 millimeter, non-specific area that enhances. It's hard to characterize morphologically. We can't find it on the pre-contrast scan. And although a focus in our lexicon is very distinct from a mass, we know in clinical practice, things are at a continuum, and actually changes will be happening in the 6th edition that will make our life easier between these two. So our focus currently that's unique from BPE, that has no fatty hilum, that's new. Those are all kind of suspicious characteristics for a malignant process. But if the focus is not unique compared to the background parenchymal enhancement, if it's bright on our T2 water-based imaging, if we may have a fatty hilum, if it's stable, those favor benign characteristics. So a mass, we need high resolution, imaging to be able to really characterize a mass appropriately, the shape, the margin, and the internal enhancement characteristics. We assess it at the first post-contrast series, and we want to avoid washout and progressive enhancement here because that will affect how the morphology looks. So the shape may be oval, round, or irregular. The margin may be circumscribed or not circumscribed. And if we have not circumscribed margin, it may be irregular or spiculated. The internal enhancement of a mass may be homogeneous or heterogeneous, or may be rim enhancing. Now, any one of those three, homogeneous, heterogeneous, or rim enhancing, could be benign, could be malignant. Rim enhancing can be quite suspicious, but if you look at the T2 weighted imaging and you see cysts, then you know that cysts can come up with rim enhancement. Also, fat necrosis can do the same. If we have dark internal septations, typically that's suggestive of a fibroadenoma and a benign type of mass. Non-mass enhancement distribution can be focal. So we can have a focal area that's usually a duct. As you can see in the upper left, it could be linear, also ductal pattern, could be regional or segmental or diffuse. Now with segmental, the apex has to be towards the nipple, as you see in the upper right, and that may involve multiple ducts. So that could be benign or malignant. The same thing with regional, that involves more than one quadrant, may involve many quadrants, and that enhancement could be benign or malignant. The same with diffuse. Diffuse can be diffuse carcinoma or a benign process. The internal enhancement pattern of non-mass enhancement could be homogeneous, heterogeneous, it could be clumped. That really is an aggregate of multiple little foci in some kind of cobblestone pattern that could be confluent or not. Or it could be cluster ring, as the example I have below. The type of findings we notice and we have to report are intramammary lymph nodes, a skin lesion, something that does not enhance. Other associated features, such as involvement of the pectoralis muscle in a patient with a new diagnosis of carcinoma and a known new breast cancer, a fat-containing lesion, an implant rupture, such as an intracapsular rupture in a patient with implants, or other incidental findings that are not in the breast or the axilla, such as this paraspinal lesion. The kinetic curve and the assessment, that's important along with morphology. Abnormal enhancement really is defined as enhancement that's at a higher signal intensity when you compare it to the surrounding normal type of background parenchymal enhancement on a contrast enhanced scan. So the standard kinetic techniques are actually dynamic measurements where we look at the uptake and the washout of the contrast in the tissue, and we monitor that. We monitor it over a period of time following our contrast injection. Tumors usually have very permeable, very dense vessels, and so we get relatively rapid blood flow and a very high type of microheterogeneity, and that really causes tumors to enhance more rapidly than the surrounding normal tissue. And that's where the kinetic curve assessment is important. The analysis involves an initial phase and a delayed phase. So the initial phase is usually within 2 minutes or until your peak is reached. So that is broken down as fast, medium, or slow. And then we have a delayed phase that happens after 2 minutes, and that can be persistent, plateau, or washout. The washout, usually in the delayed phase, speaks of malignancy. A plateau is sort of an indeterminate thing, could be benign or cancer, and a persistent type of delayed phase analysis and enhancement really speaks to something benign. our BI-RADS assessment categories. We combine reporting when we do our MRI reports. So we rarely will we give MRI 0, needs additional evaluation. We certainly may give it a 1, -2, benign. A 3, usually a probably benign involves a short-term or some kind of interval follow-up. A 4 is suspicious abnormality. 5, highly suggestive of malignancy. And 6, known biopsy-proven cancer. So our overall assessment and the management of the patient really describes everything we saw. We get a summary basically of our MRI findings, and we incorporate the assessment, the BI-RADS assessment category into our final summary. And then patient management recommendation really has to correlate with whatever assessment BI-RADS category we assigned or explain why it doesn't. If we give something a 0, which should hardly ever happen, then we have to make a specific suggestion for what else we need to do here to get the answer for the patient and her clinical care team. What is the next action that has to be given? If we give something a 4, a suspicious abnormality, then the report should really indicate that we're recommending a biopsy to be performed on that suspicious abnormality. So the reporting summary. The current MRI exam, it needs to be compared with priors when appropriate, because we may have stable findings from prior exams or new findings or enlarging findings. The indication for the exam, whether it's a high-risk patient or newly diagnosed breast cancer patient or for indeterminate workup, and the patient needs to be evaluated. So that's the indication for the exam that has to be stated. And we have to organize the reporting. So it's a brief description of the composition of the breast tissue and any other pertinent imaging findings that we saw on our MRI, and then give our assessment and management recommendation that really should correlate and an explanation if it doesn't. The report needs to be succinct, easy to understand, using approved language for our MRI lexicon and our atlas, our BI-RADS atlas, because somebody is going to take a look at this and perhaps follow that patient a year from now, another radiologist. So we all have to be speaking the same language so we all understand what this reporting means and give the help that our healthcare team needs to take care of this patient. And I want to thank you for your time and my email address if you have any questions. And again, thank you for the invitation. I appreciate it very much. I hope to see you in person soon. Bye-bye.
Thank you very much, Dr. Destounis. That was very informative, and we hope next time you will come in person. Our next speaker is Professor John Lewin, who is an Associate Professor of Radiology and Biomedical Imaging, Division Chief of Breast Imaging at Yale University School of Medicine, President of